We have Dr. Hardeep Kainth, who is a physiatrist and is the medical lead for spinal cord injury rehabilitation in Edmonton. And Willy Gateka is a person with lived experience of spinal cord injury, and I'm sure he'll tell you a little bit more about that. Go ahead, Hardeep.
All right. Thank you, Julie. Wow, we have so many people on the line. It's great to see this many people turn out, which is wonderful. So thank you for the intro. I'll let Willie introduce himself shortly when we get to that slide. First, I kind of want to introduce the topic at hand, and then we'll get Willie's experience with orthostatic hypotension. So just some objectives. We first need to review some of the physiology of why persons with spinal cord injury often will have orthostatic hypotension. Then we'll understand Willie's perspective and how it's been an impairment and when it presented. And then we'll talk through strategies, pharmacologic, non-pharmacologic, and differences in acute and chronic management. So with spinal cord injury, this is my favorite picture because it really does give us a really good idea about the autonomic dysfunction that occurs, which affects every body system below the level of injury. So when we talk about orthostatic hypotension, we really need to understand this imbalance between our parasympathetic and our sympathetic nervous systems. We know that from a parasympathetic lens, the vagus nerve has cell bodies up in the brainstem, but the sympathetic nervous system has cell bodies present at each level of the spinal cord, from T1 down to L2, and then from T1 to T4, there is a track that goes up the sympathetic chain to give innervation to the cervical spine. So in essence, every level, cervical, thoracic, down to L2, has a sympathetic cell body each at that level. So if you were to get, let's say, a T4 complete injury, you would lose a significant portion of your sympathetic function below that level. And varying degrees of incompleteness, you would have varying control of that sympathetic function below. But regardless, that imbalance is what gives us a lot of problems in all of these various organ systems. So as we're talking about orthostatic hypotension, we really need to focus on the cardiovascular implications of that. We know from a cardiovascular point of view, our sympathetic nervous system is very important because it not only increases the contractility, but also the heart rate, and it also focuses on vasoconstriction, obviously, right? So it is essential for our basically our AV node to sinoatrial node to AV node to all of that, the inotropy and the chronotropy of the heart. What we often forget is below that level of the heart. So T1 to T5 is the heart. Below that, we have a huge body of vessels, right? The splanchnic blood vasculature and the vasculature in our lower extremities. Combined, they are the largest reservoir of blood in our body. So if we lose control to that reservoir, we get some significant issues. One being orthostatic hypotension, and the other, which is not the topic of conversation today, but autonomic dysreflexia. So that's often overlooked when we're being trained in medical school and in wherever else, other parts of training. We often forget that T6 down to L2. So that's just kind of the prerequisites, and then we'll get into autonomic dysreflexia in a minute. But I'll introduce Willy at the moment. Willy, thank you for joining us. Can you introduce yourself?
Thank you, Dr. Hardeep. My name is Willy Gateka, and I'm 49 years old, as you see that there. And I got into a spinal cord injury while playing with kids at the trampoline. And I've been like a quadriplegic because of the accident at the C6 level. And I've been a patient of Dr. Hardeep for more than 4 months. And there was a lot of going on since I got into the accident, because the accident happened last August in 2025. And I left the Penrose Hospital in December 19th. So now I've been at home, so no major issues since that time. And that's pretty much what's going on for now. Yeah.
Excellent. So we'll get into some questions later, Willie, about orthostatic hypotension, but let's just
Mhm.
review first. So some of the cardiovascular complications acutely after a spinal cord injury is the neurogenic shock. So because of the loss of sympathetic tone um, below the level of injury, we lose the ability to have constriction, vasoconstriction of our blood vessels. So that peripheral vascular resistance is gone. So we can't increase our preload to the heart. So we develop hypotension. Usually in that case, our heart would respond by trying to beat faster. So in like septic shock and other types of shock, that is what the heart would do. But because we've also lost control of our rhythm generator in the heart because of the loss of sympathetic tone, we also develop bradycardia. And because of the peripheral vascular resistance loss, we get dilation and we develop hypothermia, right? So that is the triad of neurogenic shock that's often presented acutely. So most of our patients with significant complete cervical injuries or high thoracic injuries have to be put on vasopressors, which we'll talk about. The other thing as well, as we know, because of that loss of rhythm generation and rhythm control, we also develop that bradycardia, and that can lead to bradyarrhythmias, heart block. And so that's the most frequent arrhythmia that develops. Other arrhythmias can develop, but definitely bradycardia is the most significant. That can be quite problematic where people, when they're maybe suctioned in the ICU, shortly after their spinal cord injury, they may actually end up coding because they become so bradycardic and they develop heart block. And so then we have to use things like atropine prior to them being suctioned. Um, but generally, when it comes to these complications and including orthostatic hypotension in the acute period, 6 weeks is about that mark where we need to hold on and manage, and then things start to stabilize at about 6 weeks. And we'll talk about that. So orthostatic hypotension, the actual definition would be kind of a reduction in blood pressure, systolic of 20 millimeters below what their baseline is, or 10 millimeters of mercury for diastolic within 3 minutes of standing, or head up tilting to 60 degrees. So I thought I'd throw in here real quick because people often ask me whenever I talk about spinal shock, they also talk about, neurogenic shock. They also want me to talk about spinal shock. And they kind of mirrored, but they're two distinct entities. Spinal shock is our loss of reflexes, spinal mediated reflexes caudal to the level, so below the level of the spinal cord injury. And these begin to return in a phased approach. And the late hyperreflexic period, as you see here, at number 4 is when we start to develop things like spasticity and autonomic dysreflexia. So that usually happens in that 4 to 6 weeks and further out from there. And the first kind of reflexes that develop are going to be like the delayed plantar reflex, and then your polysynaptic cutaneous reflexes, so the bulbocavernosus and the anal wink reflex. So when we do our INSCI examination, our spinal cord examination, we're often testing an anocutaneous or anal wink reflex because that really tells us when someone is out of spinal shock. So again, going back to the cardiovascular complications, this is just another graphic telling us of what's going on. The loss of sympathetic control gives us this passive dilation. The preload decreases, stroke volume decreases, cardiac output decreases, and then we get all of the trifecta of neurogenic shock. So it's very important that patients are acutely put on vasopressors. The vasopressor of choice that we use is generally norepinephrine because it stimulates both alpha and beta. So you get both chronotropy and inotropy, which is essential. And that needs to be put on. It's often put on in the field if it's a significant injury, and then it's generally continued for 3 to 7 days post-injury, right? And the next slide we'll talk more about that. But and then the other thing is bradycardia. We spoke about that briefly. Is avoiding vagal maneuvers, maybe atropine beforehand, and in the rare cases, we sometimes have to consider a temporary cardiac pacemaker in patients if they're continuously dropping out. But like I said, we try and hold on to that 6 week mark as best as we can, if that's possible, before implementing something like that. So this paper was published in 2024, and it's the most updated guideline, really. And actually, a lot of the authors are from Canada, so it's interesting. Brian Kwan's from Vancouver, Michael Failings is from Toronto, and they updated it because back in 2013, there was a large neurosurgery conference in the States, and they went on consensus. And what they found was they would keep a MAP target of about 80 to 85 millimeters of mercury for 3 to 7 days post-injury. That's what the consensus was because of the risk of ischemic damage to the cord. You can imagine from the actual spinal cord injury itself, you get a lot of ischemia, a lot of potential for ischemia from the inflammation. And so you do not want someone to get an acute ischemic injury in their spinal cord at the same time as just developing a spinal cord injury, right? So because of that, you want to maintain perfusion as best as you can. Hence, you put them on a vasopressor. They updated this to be 75 to 80 and no more than 90, just because there is high risks as well of having too high of a MAP drive as well. So this is the most updated guideline. So what happens really after that is where we develop into orthostatic hypotension. While they're on vasopressors, we're okay, right? We're artificially increasing the blood pressure, then we wean people off vasopressors. And this is where kind of Willy and I's journey counteracted. So I saw Willy when he was in the ICU, I think 3 days, two days after he got transferred from Calgary back to Edmonton. So still in the acute, very acute period, I think like 8 days after his surgery. And this transition was just about to happen. So he came off the vasopressors, and now he was on midodrine, which is one of the medications that we elevate our blood pressure as an alpha-1 agonist that will help to constrict our peripheral vasculature to increase blood pressure. So, Willy, if I could ask you, if you can remember that, when you're in the ICU, do you remember how this affected you? So as they're weaning down off the vasopressors and we were coming up on other medications, how did that affect you?
I I really haven't. I really don't remember all the details, but because there was a profusion of the medicine that I had to keep on when I was in the ICU, and so it was supposed to be like a 2 weeks profusion, and I was just laying down like in my bed at that time, and it's when after those 2 weeks, that's when I got transferred from the ICU to the general like admission over there.
Yeah,
And
Willy, it was so when we started it, I remember you were really struggling to sit up. You couldn't do any sitting activities initially because your blood pressure kept tanking, kept dropping. And so that was right
exactly.
when we were transferring you from the ICU to the ward. So it impacted what we were able to do massively because of this drop in blood pressure. And
Hmm.
so when you went to the trauma unit, your ability to participate in therapies with that,
Yeah,
do you remember that? I think you remember that part of it, right?
yeah, I remember that part. So that's where I was at. When I was in the ward, that's when I was able to start participating more often into the activities like the physiotherapy and stuff. But
Yeah,
still, the blood pressure.
for you to be able to do that, Willy, I remember we had to increase the medications quite significantly. Willy had to be put on 3 times a day midodrine dosing. I think we went up from 5 milligrams to 10 to 15, and then we even
Yeah,
had to start another medication called fludrocortisone to stabilize that blood pressure. So quite significant um, management that we had to do to even get you to participate in therapy. So,
exactly.
so at the moment, or like when it stabilized then and now, how do you think do you get drops in blood pressure now and how do they affect you now chronically? So now after getting home.
Oh, since the okay, when I was at the Grand Rose, um, when there was like activities getting the Metrodrine, like I was able to stabilize the blood pressure, but on the weekend when there was no even like a therapy, uh, it felt like the Metrodrine I was taking like in the afternoon increased my blood pressure really high, right? And it's at that time when Dr. Hardeep had to ask me like, okay, let's take like on the weekend, you're gonna maybe not take the Metrodrine and see how your blood pressure will be. So from there, we start like reducing the Metrodrine I was taking. and I was able to keep like the blood pressure down a little bit. And when I went home, so now that's when we decreased, because it was no, before leaving the hospital, the Grand Rose, that's what they asked. I was taking the afternoon metadrin as needed. So when I was taking the metadrin as needed, that's when I was able to find out like I didn't need really the afternoon metadrin. And now since I'm taking only the morning like the metadrin, just to make sure that the blood pressure doesn't drop during the bowel routine I'm doing every morning. So now my blood pressure is kind of stable, no issue anymore.
Perfect. Thank you, Willy. Yeah, so that trajectory that Willy just explained to us is very, very typical of our patients in that hyperacute period, post vasopressors, lots of difficulty, needing to have blood pressure doses augmented quite significantly with midodrine, like I said, fludrocortisone. And then as we came out into the rehab phase and he was getting more used to being upright, we'll talk about what happens, our body actually responds to that. He was able to reduce doses all the way down to kind of PRN, and now he just takes it in the morning. So this is a very typical time course for what we'll see for most of our patients. Thank you, Willy.
You're
So,
welcome.
so what are the symptoms some of the symptoms that Willy was experiencing quite significantly was these lightheaded, dizziness, fatigue, blurry vision. We're trying to prevent like these syncopal episodes, right? And as you can imagine, if that's happening and you're trying to do inpatient rehab or you're trying to participate in activities of daily living at home, that would be very, very difficult if this was continuing to happen. So very important that this is managed. Um, so what are the causes, right? So we know that it's the loss of sympathetic tone. We know it's the loss of that vasoconstriction reflex in the lower extremities, which leads to low plasma volume. It can be affected by hyponatremia, so low sodium as well. And then if people are deconditioned, so if they're in bed for a long period of time, they'll be very deconditioned from that, right? And the big thing is this affects a large percentage of our patients, right? So in acute SCI, the reports are up to 75 to 85% really of our patients, more frequently, obviously, in tetraplegia with people above the level of T6 with more complete injuries. And generally, in the chronic phase, still 38% of people still report symptomatic hypertension as being problematic and affecting their activities of daily living. So still a problem, but less so than acutely. So what happens to drop it from that 75 to 85 to that 38%? We do have compensatory changes, right? So our vascular beds start to normalize. The other vascular beds contribute blood pressure. The kidneys as well start to react, and you start to activate your renin-angiotensin system, which means you start to retain more water, which increases your preload. Even your receptor activity and the sensitivity to those and those reflexes start to kind of reduce, and you start to develop a little bit more tone in the muscles, which in itself starts to compress some vessels, so you actually get a little bit more flow back to the heart. And then you develop tolerance, right? You develop tolerance to those symptoms. And a big one that they think is this autoregulation of cerebral blood flow. So the actual cerebral blood vasculature responds to lower amounts, right? It doesn't react in such a way where you get these syncopal episodes. So all of these things combine to drop that from that 75 to 85 down to 38%. So what do we do acutely, right? So if someone's acute, maybe, or even in the chronic period, acute to chronic period, what are some of the non-pharmacologic treatments that we can do? So compression stocking is an abdominal binder, as we mentioned in a previous talk. It's kind of one of the mainstays of treatment in terms of non-pharmacologic, because we're trying to provide some external force to try and promote blood flow back up to the heart. And so that's important. Is it supported massively in the literature? I would not say so. But again, anything in the spinal cord population, the literature is lacking, and we have small N numbers. But despite this, we know from our own experiences that if patients come off using compression stockings and abdominal binder, they have higher rates of symptomatic orthostatic hypotension. One of the things we have to remember is using them concomitantly is important. Trying to put on abdominal binder without a compression stocking is only going to be so beneficial. Together, they're going to be utilized in a better way. So any out of bed activities, we want them to use both. From a respiratory point of view, we often recommend an abdominal binder anyway to increase peak expiratory flow in that ICU period. So again, there's multiple reasons to use them. So that's why generally our patients have them on. We have to remember, where is the largest reservoir of kind of fluid accumulation in our body? And it's in our abdomen. So if we can provide some external compression to the abdomen, we may end up pushing some of that fluid back into our vasculature and up into our heart, and hence help to perfuse our brain. So it's very important. Whole body vibration plate therapy was interesting. Again, a bit more of a chronic one. But it does show in the literature that you can increase standing mean arterial pressure in individuals with SCI. The study was a bit lacking in terms of what the clinical symptomology of that was. Did it actually help to improve symptoms, or was it just a very small increase in mean arterial pressure, which wasn't really clinically relevant? So that's still kind of out there. The one that is supported more in the literature is functional electrical stimulation. So we know that if you can stimulate your lower leg muscles, so the large leg muscles, so quads, hamstrings, your plantar flexors, ankle plantar flexors, you can actually promote blood flow and increase in preload and decrease orthostatic hypotension symptoms, and you can allow people to stand for longer duration. So that is definitely supported in the literature. The other non-pharmacologic treatment that's out there now is obviously spinal cord stimulation. The two types that people have studied with epidural spinal cord stimulation and then transcutaneous stim as well. So epidural spinal cord stimulation is obviously where they implant electrodes on the surface of the spine, a lot more invasive, but it has shown that it definitely can, especially the lower thoracic spine, can increase blood pressure, especially when it's turned on. In Calgary, Aaron Phillips has been doing a lot of transcutaneous stim, and I know Dr. Charbonneau and team out there have a few patients in Calgary that have a thoracic transcutaneous stim in place that helps them. But like I said, the majority of patients in that chronic phase end up stabilizing anyway. And so they would need to be fairly bad from an autonomic perspective to have really persistent dysfunction, orthostatic hypotension, that we can't manage with the regular means that we usually manage with medications and some of the other non-pharmacologic treatments. So it's good to know it's out there, but I just think it's a low patient population number that would actually need to go that far at this point in time. When we talk about pharmacologic treatments, the major one that we use is midodrine. Like I said, we use this right from the ICU. This is what Willy was on. And it's an alpha-1 agonist, and there's not very much side effect issues with it long term, apart from supine hypertension. So if you use it in an inappropriate time, so say you take it at 10 o'clock at night and you go to sleep at 11 or 12, you're going to get a high blood pressure overnight. And with individuals with spinal cord, we want to avoid episodes of hypertension because their vasculature is not used to elevations in blood pressure, especially when we're doing it artificially. Similar reason why obviously we don't want people to hang out with AD at high blood pressures, right? So we try to avoid that. So in the chronic phase, we give midodrine really in the morning and in the afternoon only. And then generally we only give an evening dose if they're up for extended periods of time in the sitting posture or in their wheelchair up until late at night. And then the latest we give that dose is generally about 5 o'clock. Fludrocortisone is a mineral corticoid, so it works at the level of the kidneys to retain fluid. This is kind of like a basal, and like it increases your blood pressure basally, or across the board. So it's a once a day medication. The problem is it does it via fluid retention. So you have to be careful. Individuals with spinal cord injury already have reason enough to retain fluid. And so now you're adding another agent that retains fluid. So I often try and wean this medication in the chronic period. And I only ever use it if someone is having lots of peaks and troughs with their midodrine dosing. So they elevate and then the midodrine kind of wears off and then they kind of dive down and then become syncopal and it's going up and down. The fludrocortisone gives us that nice basal rate, but you don't want someone to come in with flash pulmonary edema, which I've seen before when someone's been left on fludrocortisone long term. Droxidopa and midodrine are the only two FDA-approved agents to be used. But the problem is we don't have droxidopa. It's only available in America, not available here. But it's excellent because it's a synthetic precursor to norepinephrine. So how we're using norepinephrine as a vasopressor, droxidopa is excellent because it does the same type of thing, but with an oral agent. But unfortunately, we don't have it. The other two agents have a very small body of literature supporting their use, but in extreme cases where we can't get what we need to out of midodrine and fludrocortisone, we may go to one of these other agents. Pyristigmine, I will just tell you to be cautious with because it also drops heart rate. And so a lot of people that have orthostatic hypotension also have corresponding bradycardia. So we often can't use that medication because of that. So the other thing I want to focus on here is reviewing secondary and associated conditions, right? Why else could someone's orthostatic hypotension be significant? Always screen for postprandial hypotension. So when this is a common complication post SCI, patients always tell me that post eating, they develop lower blood pressures, and that could lead to pre-syncope. So lightheadedness, dizziness. And that's because of shunting of blood to the intestines and the GI tract to try and process all of this food. So it's very important that if that's their presentation, you then think about smaller meals, spacing their meals out to try and reduce that before you start introducing medications. Physical exertion, obviously alcohol intake, hot environment, all of these things can lead to dehydration, low plasma volume, and then can lead to orthostatic hypotension. Deconditioning after prolonged bed rest, we spoke about. And then there's multiple medications that you need to be able to screen for that can also contribute to having orthostatic hypotension. So before we start them on medications, pharmacologic treatment, we want to screen for all of these things. Try some non-pharmacologic treatments, which is often just compression stockings, abdominal binders to start with. If they have FES available to them and they have a home unit and they're using it for something else, you can consider if they're doing like using a standing frame, you can have them do FES on their lower extremities before they stand, and that will allow them to stand for longer periods. So one of the things I wanted to talk about briefly is the implications. So what? So if someone has a blood pressure, a resting systolic blood pressure of 90, 85, and they're not symptomatic, what's the big deal? And more, there is research coming out showing us that frequent hypertensive episodes are directly linked to cognitive impairment because of the cerebral hypoperfusion. So it's important for us to think about that because in the literature and in the spinal cord body of what we're taught, we often only treat if people are symptomatic. But I think we have to challenge that to some degree. And in my practice now, if someone has a systolic blood pressure of below 90 resting and they're non-symptomatic, I will still treat them to try and bring their blood pressure up to a resting systolic blood pressure of closer to 100. Because I feel that if you're at 90 and then you drop, say you're doing bowel routine like Willy's talking about, you drop into the 70s or the 60s on a consistent basis, you're causing ischemic episodes every time you do that. And that is going to have long-lasting consequences in terms of dementia risk and vascular dementia risk going forward, right? In the general population, orthostatic hypotension is associated with a 20 to 30% increase in all-cause dementia and vascular dementia, right? That's in the general population. If we correlate that over to the spinal cord population who have frequent episodes of orthostatic hypotension, could be on a daily basis, right? Every morning when they're doing bowel routine, I think we need to look at that a bit differently. And that's why some of the work from Aaron Phillips and people like that doing transcutaneous stim and trying to develop other modalities for us to raise up the blood pressure is very important because I think we need to have a lower threshold to treat people to maybe a higher resting blood pressure to avoid that happening. So some of the takeaways right before we end. The latest literature has, like I said, the study in 2024, our MAP target, again, can be slightly lower, but it has a larger range now, I would say. Instead, it was 85 to 90. Now we're doing 85 to 90, 3 to 7 days post SCI. And again, that is dictated by the neurosurgery or the spine teams based on the actual injury itself. So they will determine that and they'll put that in. Generally, we use as a vasopressor norepinephrine in that acute period. And again, it's to stop ischemic injury happening to the cord. The last thing you want is someone to get, say, anterior cord syndrome, and then there's no chance of recovery, or very, very low chance of recovery if that happens. In my opinion, we need to avoid resting systolic blood pressure below 90 in our chronic population and closer to 100 and leave it there. Then comes the argument of why don't we just keep people on higher doses then? Why don't we just put them on midodrine and keep them on it and keep their blood pressure up to 120, 130, which is more normal population doses or more normal blood pressure? Because the risk of AD is still present in this population. And so if we're artificially increasing the blood pressure when we don't necessarily need to, then the AD elevation will be that much more significant. And again, with vasculature, there is not used to that. We have to be careful. So there's a risk benefit to everything that we do. And I think there is a middle ground where 90, 100, 110, that kind of is a nice systolic blood pressure to aim for, in my opinion. And we mitigate. I wouldn't try to aim for higher than that because of the risk, because the same population is at risk for AD. So managing symptomatic hypertension, again, gradual sitting that we talk about always, at least 1.5 liters of water a day, compression stockings, abdominal binder. Consider FES. And if you have it available to you, transcutaneous stim with certain activities, knowing that when you turn off your transcutaneous stim, there may not be that retained benefit. Some literature has showed has been, but it's not well documented at this point whether how long it will be maintained for and how often you need to really turn on the stim to keep that from keeping the blood pressure up. And then pharmacologic management, midodrine at this point is preferred because it has the lowest side effect profile, with just supine hypertension being the big one. And again, frequent episodes of orthostatic hypotension will increase the risk of dementia. So if someone is experiencing that, they should be seen by their spinal cord team, and management should be appropriate to that. And we should try to stop that from happening on a consistent basis, just like we are very quick to manage AD when AD is happening frequently because of the risk of stroke and retinal detachment and dissection, all of the things that are associated with AD. We should be thinking the same way about frequent orthostatic hypotension episodes. If they happen in a frequent manner, we're running the risk of dementia chronically in this patient in our patient population. All right, thank you. I don't know if I ran out over time or where I'm at, but we can.
You did great.
All right, thank you. Willy and I can take some questions.
Great. Thank you both. We have about 7.5 minutes for questions. I would love to know what your experience has been like, this is for Hardeep, in counseling patients about those modifiable lifestyle strategies like meal timing, hydration, exercise in a way that's realistic and impactful for preventing those long-term complications of orthostatic hypotension.
I think it's how you present it, Julie. So if you present it, no one wants dementia, right? So if you are presenting it in a way that you are, this is a serious issue. It's not just you're dropping blood pressure, you're getting a little bit dizzy. If it's happening frequently enough and you tell the tale of chronically over time, this is going to lead to an increased rate of dementia, people tend to listen to that approach more so, right? The elevation, obviously, in trying to get them to drink more water is also going to help reduce rates of urinary tract infections and other things. So it's not just it will help one thing, right? All of these things are beneficial. An abdominal binder, again, same thing. It helps with expiration and getting up a cough as well. So if you can try and tie in our recommendations and have more impact by doing the recommendations, because it's going to hit multiple organ systems, they're more likely to buy into it in my experience. And then obviously we do our chronic follow-up every year, and then we drill the point home every single year because chronically we're following up with people. And that consistent kind of messaging is what really helps the most.
I like sort of a follow-up question. For those individuals living in the community, and I think this is also a question for Willy as well, what red flags should prompt that reassessment? Even if you're not, like, you might be getting your routine reassessments, but what should people with lived experience be looking for in the community to say, I need to do something different about this?
Great question. So I'll give you an example. I had spinal cord clinic today, and I had a patient I hadn't seen in a year. We had an annual assessment, and he'd been on midodrine chronically. So he takes midodrine every single morning, and he's been doing it for 5 years. And so the question then is, does he need to be on it? Because now he's improved all of these other things. His fluid intake was 2 liters a day. He's never having any pre-syncopal episodes, never having any dizziness. So frequently, I would say that you should be reassessing it. Do we even need to be on it? Are we, because what he was having was autonomic dysreflexia sometimes. So are we contributing to that AD happening? So I think reassessment is important. Checking to see, does someone need to be on midodrine? And then if they're not on an agent and they're having these episodes where they are having lightheaded, dizzy spells, what we see it mostly with is first thing in the morning. So what I usually counsel patients is first thing in the morning, gradual elevation of that bed to 30 to 45 degrees if you can, with either pillows or an electric adjustable bed. Try and hang out at that position for a little while. And at that point, drink some water. Try and drink some water, increase your fluid volume. And then if you've got the time to do it, because some people are rushing to work, if you've got the time to do it, then gradually get up and do your things. And that in itself can help to manage and mitigate symptoms in a lot of cases. Because the most frequent thing that we hear, just like Willy is experiencing, is bowel routine. You get on the commode, you do bowel routine, and during bowel routine is the biggest time when someone is going to get orthostatic hypotension. There is a lot of stuff going on in bowel routine. There's pain, potentially with hemorrhoids and sitting on the commode and blood flow going down to the GI tract. And that is going to be the biggest time period. So if you can set yourself up as best as possible for that, then you can mitigate. But if you are having those symptoms in that time period, then we need to give you a dose of midodrine before you do that, right? Because what I don't want is you to have an episode of orthostatic hypotension and have syncopal episodes frequently at that time period.
So risky. Okay, one more question. We have 3 minutes. How should a patient manage their OH when it's spontaneous throughout the day? Maybe not that first morning, but they just suddenly get an episode.
Yeah, so the other thing that we ask patients to do frequently is we always prescribe blood pressure monitors for people. And generally, this is for AD, orthostatic hypertension, for both. We want to get a baseline, right? You can't treat autonomic dysreflexia unless you have a patient's baseline. And the same, you can't really manage orthostatic hypertension in the same way. So I generally have a blood pressure monitor that is, so a 5-day period, I'll have the blood pressure checked in the morning, and then I'll have it checked when they've been sitting for a period of time later in the day, just resting. And I'll kind of have that done, and I can kind of get an average blood pressure. And if you're having frequent drops in blood pressure throughout the day, then we have to think, why is that happening? Is it because of variable fluid intake throughout the day? Is it happening after exertion? Is it happening after, right? We have to look at all of the concomitant potential risk factors that are contributing to this orthostatic hypertension. Are they on current medications now? Because some people they're on midodrine, and then the dosing interval between the midodrine is too big, so they end up dropping out. So the midodrine dose will be effective, it drops off, and then all of a sudden they have a syncopal episode, and then they take their next midodrine. So there's lots of different things that we need to look at to determine why you're having this kind of up and down spontaneity with orthostatic hypertension. But there's usually a reason, and we can get to it with a good history. And then if it's something that we can't manage with something like midodrine, and that's where we may introduce, despite the risk, fludrocortisone. And I do have a few people that I continue it on chronically because of that problem. And if you've got really significant autonomic dysfunction, then you may have to be on both, right? And therefore, we may have to get additional autonomic testing if we think that you're in that category. And that can happen to people generally with both a spinal cord injury, and if you've got an additional peripheral nerve injury and a spinal cord injury, those people are really affected autonomic wise. And generally, we may have to introduce more treatment at that point.